the use of CAR T-cell is going to expand in the next few years. Right now, the marketing approval are only patients in third line of therapy, diffuse large B-cell lymphoma or primary mediastinal. We see two things. First, probably the field moving to earlier lines of therapy, but also expanding to other histological subtypes. Earlier line of therapy, this is a question that is asked by 3 clinical trials, ZUMA-7, Belinda, and Transform, with the different CAR Ts that are presently or will be very soon on the market. All of them actually try to assess whether using CAR T in the first relapse of DLBCL is of value and may beat the standard of care, which is salvage therapy followed by autologous stem cell transplant, and we are eagerly waiting for the result of this trial. There is also a possibility with some early data suggesting that in patients that are not eligible for autologous stem cell transplant, there may be a subpopulation of patients that may be able to receive also CAR T at the time of their first relapse in DLBCL. We heard recently during the ASH meeting that CAR T are also extremely useful for patients with mantle cell lymphoma with a very high response rate in the ZUMA-2 trial, with 2/3 of the patients with this disease failing anthracycline, bendamustine, BTK inhibitors, and obviously anti-CD20, having been reaching a CR, which appears to be prolonged. So this is a great hope. And there are a couple of trials being performed in patients with follicular lymphoma with probably quite successful result of achieving a CR in patients that are multiple resistant. I am not even addressing the primary CNS lymphoma or other rare subtypes, but I'm quite convinced that this kind of therapy will be helpful for many patients with lymphoma in the near future.